Hi, welcome everyone. We're going to get started here. This is our first webinar of the year, Ready for Action, LED Lighting and or Retrofits. The purpose of today's webinar is to discuss these two projects and to really try to maximize the savings once you get started on them, or at least give you an idea of what to expect when preparing for them. We have a number of industry experts and case studies to help you with this. To announce our hosts, I'm Michael Pagel, Program Manager of Green Healthcare. We also have Ian Jarvis, the Executive Director of the Climate Challenge Network, and Amandeep Deol, the Technical Director of the Climate Challenge Network. Just general housekeeping, this webinar is recorded and will be sent out to all members on our group. If you have questions, please ask at any time. We really encourage this, and we will take breaks to announce those. Our program sponsors are ISO and Enbridge, and as always, we really appreciate their support in making our content happen. And with that, I'll pass it to Ian to go through the agenda and start us off.
Yeah, thanks, Michael, and hello, everybody. As Michael said, this webinar, perhaps even more than the rest, is a lot about interaction. There's a lot of expertise on the panels we have here, and this is the right time for everybody to ask their questions, make their comments. As you know, you've got the raise hand option there, or you can simply type into the chat, and one of us will be monitoring the chat all the way through, and we'll interrupt the program for you. The Q&A we would prefer that you use. If you've got questions that we don't get to during this, please do put them into the Q&A, and we will be sending out formal responses to the questions, and the answers we'll get from the right people if we don't get to them today. So use the interaction. It's your one chance every couple of months to get to talk to people about kind of real issues and best practices about doing things. I'm going to begin today with a bit of an overview around how we see the world in 2021. Then, as Michael said, we've been in touch with a number of you around LED lighting retrofit projects, and there seem to be a number of recurring issues that we want to get to. So the idea of getting it right the first time. And Amandeep's going to walk you through another visit to OR ventilation, going deeper into the conversation that we had back in August. This one could also be called Getting It Right the First Time, because we're looking at case study after case study of OR ventilation controls and mechanical retrofits, and they're almost invariably areas where they can and could be done better, and after we've gone through it with the hospital, they'll typically go back and make further adjustments. So a world of getting it right the first time, and as I think Tom Peters said way back in the day, if we haven't got time to do it right the first time, when will we ever find time to do it over again? So big day around this, and these are the two focus subjects that we want to address today. Next slide, please. So welcome to 2021, new year, new challenges, new opportunities. You've all seen the cartoon on the right-hand side before. I think we're going to put a face on the climate change wave, and we'll call this our icon for 2021. And when the first part of this madness disappears, we'll get it round and replace it with something different. But we still see the world the same way. We're consumed with COVID right now, no more so than in the hospital sector. And we can see how the governments are spending money right now, so we just know there are economic fallout coming to follow. But once again, 5 years from now, climate change is still going to be there, worse, more intense, more acute than ever. And we just have to be planning for that today. And our commitment to all Greening Healthcare members is to keep you ahead of the curve, to keep in touch with what's going on, and make sure that as the world unfolds, that you're as ready as you can be around sustainability and climate and energy efficiency action. So let me just pick on a couple of themes which really set the stage for today, but they also set the stage for the whole year. And at the end, I want to kind of walk through a little bit with everybody what our plans are for Greening Healthcare for the year, to kind of hopefully connect the dots as to these are the things that we think you need to have and you need to know, and this is how we're going to try to develop them, and then you can plan your world for the rest of the year. So green infra, so we're going to have we think we're going to see the first signs of the economic fallout, as we call it, and it's kind of in two strange ways. One is green infrastructure funding is already starting to flow. So Ontario schools have already seen about 180 million of capital funding going in first to respond to COVID, the first wave. Then through the CAIF, the Climate Action Incentive Program, looking at the returning the carbon tax revenues that the federal government's collecting from both of our provinces, returning that back into ongoing capital projects. Everything we've seen so far confirms that the government is true to form, that the turnaround they require when they have money available is really, really short, and the projects have to be built really quickly. So this for us is everything around, we can expect a good deal of infrastructure funding over the next 2 years, and we're committed to help you be as prepared as you can be to be ready with the right projects at the right time going forward. So for your interest, CAIF, again, the Climate Action Incentive Fund, the CAIF funding that we've seen so far is cost matching. So the government puts money in, but expects the organizations, the institutions to match funding. So being prepared with your executive, knowing that putting some money aside so you can match the funding when it's available is there. Again, as I touched on, the second fallout from what's happening economically with the world right now is going to be pressure on operating budgets. Nothing new to you folks, but it can only become more intense because the government needs to recover from the spending, the massive spending that we've seen recently. At the same time, the rising price of carbon is going to be pushing up utility costs. At the same time, you've got, in Ontario at least, next generation energy efficiency incentive programs coming. We have the ISO and Enbridge Gas on the call, and in the next webinar, we'll ask them to give an overview of where they're going. But all of this economic picture says there will be real pressure on lowering costs, and the utility budget will be a key area. And as part of greening healthcare, you know what that reduction potential is. So again, being organized around responding to operating budget pressures, and at the same time being ready for infrastructure funding, which will be coming, that can help a lot to move things forward. Those are our key themes for the coming year. Finally, for this introduction, at the December 15th webinar, you recall we polled members the priority areas that they were interested in. Ventilation systems, you're absolutely correct. That's where the biggest part of the savings are, with the shortest paybacks. Low carbon central plants, we think, is the key area to be ready for infrastructure funding when it comes, and it requires doing things differently. It's not like for like replacement, it's the low carbon pathway. That's going to be a focus for us this year, and I'll touch again on that at the end of the webinar. There was a good deal of interest in going beyond energy, so green procurement, green practice. We spoke this morning with Shared Services West and have real interest there in having them contribute to the idea of what is a world of green procurement, which is quite different than how we procure right now. What does that look like? A lot of interest in water conservation, and as you'll see for today's program, the idea of do's and don'ts around lighting retrofits. So these are the things you identified as priorities. We think you're absolutely correct. These are the priorities, and these need to fit into the emerging world that changes all the time, but we think the themes for 2021 are quite clear. Next slide, please. So as mentioned around the agenda, LED lighting, getting it right the first time. So there's a number of issues that, as we look at project after project after project, in various forms, they seem to arise every time. And so we've brought together a panel of technical experts and a hospital who's gone through a comprehensive lighting retrofit project. But this is a collective. This is all about everybody on the call as well. Whether you've done a lighting retrofit project, we know that Rab from Royal Vic is there. We know a number of the Alberta hospitals have been through lighting retrofits. I think Alan from Markham Stouffville is on the line. So we know you've done lighting projects as well. So please raise hands, use the chat box, use the Q&A part. But let's see if we can get a common understanding. What we're seeing of this lighting story so far is that today is going to be kind of foundation laying. We want to get as much input as we can. And then we're going to be talking to hospital members and to the industry about, is there a way of standardizing this whole procurement implementation process to get significantly better outcomes than we're seeing in the field right now. But today is about information gathering, and so please be ready to push the button and let us know your thoughts. We have, thanks to Harry and Franz, we have their database from Alberta Health Services, which is a comprehensive review of all of their facilities in terms of how much lighting has been done. I've got a much smaller data set of surveys that we've done with you guys, with Ontario members. But the picture here is the bottom right-hand corner, that only around 30%, even though LED lighting's been top of mind for maybe 5 years now, only about 30% of hospitals have been retrofitted in Alberta, and so far. And it's a similar number for Ontario. There's some that feel they're almost complete and others that have barely started. So it's substantially less than 50%. So this is a good time to do this, because if we can learn lessons from where we've been before, we've got lots of scope to apply those lessons to do an even more effective job on the projects yet to come. Our panel, let's say we have Jim and Mike and Sergio from the industry, I think all of whom you've heard on Greening Healthcare events along this line before. So there's a big update happening here, and we've got some very specific questions, but in many ways, we're more interested in your questions than our questions. And all in his own soon, we got Rob Simpson back again from Ontario Shores to speak to the experience of the owner. Let's say there's a number of you in the audience today. We have more than 30 hospitals on the call today. There's a number of you that have been through this experience again, so please don't be shy about again, raising your hand, and let's make this intelligence gathering as rich and full as it can be. So welcome panel, thanks for taking the time to do this. And I'm gonna put questions out there. I'll volunteer some, or volunteer somebody for each one, but please feel free to both keep your response short so that we make time for other people to chip in there. And to start on the right foot, I'm going to answer the first question, which is, we've tracked a number of projects that we know lighting took place, and typically we're seeing the actual savings compared to the forecast savings from the lighting audit in the range of 65 to 75%. So it's a significant shortfall. And really interested, Jim, in as you're seeing projects take place there, what has your sense been in terms of the realization of savings versus what was called for in the first place?
Well, some projects that people claim that they don't achieve the savings that they were promised. And the response to that is, we really need to use due diligence to do a proper analysis. Sometimes the hours of operation in a certain ward or an area of a hospital will change just from the functionality that it becomes a patient area or a surgery area. There's lots of things that can affect the electrical consumption just based on doing a proper analysis, doing pre and post measurement and verification of the circuit load. So it's not just about 60% savings on the electrical bill because the LEDs are lower consumption. Yep. There's a lot more to it. And also there's not just electricity savings. Obviously there's a maintenance savings of not having to incur the costs of lamps and ballast. Not only that, but the labor to install those over the long life of the LED.
That's That's helpful. So going beyond the 60% rule, and I think what everybody is learning, especially in hospitals, lights don't run anything like as long as we think they do. So that's where most of the, you're right, the fixtures do come back, do come down by the efficiency of the LED replacement, but the hours of use are way longer. So the economic question is up for grabs. The too bright for comfort. I have yet to talk to maybe there's a couple on the call today, which would be helpful. Yet to talk to a hospital where they don't relate to that. That this, oh man, the LED light is too bright. We have to turn it down. Rob, did you get any of that at Ontario Shores?
Yeah, like you said, it's not uncommon. It's pretty common result. You know, LED lights are a lot more directional than a typical tube, right? So that's part of it. You know, a big part can be, you know, sometimes these tubes are, you know, 15, 20 years old. So they've lost some efficiency over the years, or they're burnt out altogether. And we go and slap in, you know, some brand new bulbs, and
yep.
You know, the result is a lot different than what we were expecting.
Right. So again, people in the audience who've had an LED retrofit, if that's been your experience, can you just pop something in the Q&A or the chat? Because then it's kind of a little mini survey that we're doing here. And Mike, in your experience with all the projects that your group has gone through, is this a common problem? And if so, what's the solution?
Yeah, it's definitely an issue that we see. I think that the best solution for the comfort issue around LEDs is to provide more control options to users, to give them dimming functionality and localized control. One issue that we see is, for example, in nursing stations that are operating 24/7, a higher light level is required during the day versus an overnight shift. So providing that level of control as part of the lighting retrofit process, and considering that from the inception of the project is something that can help minimize that overlighting later on.
But more controls are going to cost more, right?
Yeah, it's going to increase that initial investment, but we see the controls as something that's underutilized in the lighting control or lighting retrofit space. It's something that can actually help build a stronger business case if you're assessing it on a life cycle basis and looking at that project over a long timeline versus just assessing it on a payback priority.
Okay, I'd be happy to hear back from, again, other people in the audience, but you know, a lot of the areas that are too bright, we've got to look at them. They're in corridors and spaces that don't need kind of variable light levels. So intrigued with that whole too bright for comfort. And Rob, as you said, it's a different kind of light and it has that effect. And when it's too bright, it can be quite uncomfortable.
Ian, we have Martin Schubert from Microgrounds. He has his hands raised, so you want to make a comment on this?
Yeah, fire away, Schubert.
So a few years ago, I did a LED retrofit at another hospital, and of course we were going to have about 3,500 to 4,000 K lighting in every area, and we knew that we were going to get a lot of complaints from various staff who would, and it did happen. So what we did was, in our pre-planning, we did engage with OCAL, telling them that this is what is going to happen, and be prepared for that. So whenever we completed a certain area, we would have a certain number of staff complaining they're getting headaches and this is too bright and I cannot work. And of course, we always referred them to OCAL, and OCAL did a very good job of taking care of it. We did inform them about what are the new IEE standards in our offices and in healthcare, and of course, all this did help us. So we engaged with OCAL, which helped us immensely during the LED projects that we have done.
Okay,
Also,
and I see some more comments coming in, but let's slide down this chart a bit. I want to bring Sergio in. What's the latest on ballast compatibility with new LED lamps? Should we be, especially if we're doing it incrementally, where we're changing lamps out as they burn out to LED, do we need new ballasts?
The simple answer in most instances is that for the purpose of optimizing performance, the answer would be yes. But there are instances where the ballast is new. You've tested a combination of various manufacturers' lamps with the existing ballasts. They're in good condition, they operate. But the concern there is that if you don't have a uniform installation where the date codes and the manufacturer of the ballasts on site, if you can't verify that indeed they are going to perform from wing to wing, floor to floor, you run the risk of during your project needing to supplement the installation with additional ballasts. So we recommend replacing ballasts that are certainly over 5 years. They're outside of their warranty period. But first and foremost, we recommend an initial assessment of what's on site, some samples to verify that what's on site will accommodate a various assortment of lamps, 2 foot, 3 foot, 4 foot U lamps. You run the risk of some manufacturers' products working well on one ballast and not necessarily on another. But for the most part, any of the newer products that are being introduced into the marketplace will certainly work on the bulk of newer electronic ballasts. Over the course of many years, we've had many versions of ballasts go out into the marketplace, including our own at Signify being the Advanced Philips brand. And even in some of those products, some of our newer lamps will not work on those older style ballasts. So my suggestion is that you assess what you have. And the best way to know that is to go into your central stores, see what you have, send some photographs over to a manufacturer such as myself or one of your partners. And from there, also the product that is being removed as you do maintenance. That's probably the best sampling that you have. Utilize that. The other option is that a manufacturer or partner will send you a grouping of products to install for the purpose of assessment. And over the years, we've done plenty of that.
Rob, on the question of fixture replacement or relamping, reballasting, what choices did you make at Ontario Shores?
Well, correct me if I'm wrong, Mike, but we did complete retrofits. We didn't replace any fixtures, maybe the pot lights. Around the pot lights we did. Here being mental health, we have a problem. We can't replace certain fixture, or we can't relamp certain fixtures because it's a forensic grade or something along those lines, which is where we're at now to try and clean up the last 5 or 10%. So that goes into a lot of our decisions as well. What's on the market? It has to meet certain, forensic grades, kind of detention grade models as well.
So they're more expensive as well.
More expensive, harder to come by. Maybe sizes might be a little bit different. There's not necessarily a one-stop shop for items like that. So it does make it quite complex sometimes.
And you had a pretty successful project, and you were just fine relamping, reballasting, rather than replacing many fixtures apart, as you say, from some pot lights.
Yeah, when we came across your basic linear, 4 foot tubes, that's a straight bulb swap, right?
Yeah.
Pot lights, sometimes it does become better to replace the whole fixture.
Okay, Jim, let me kind of pick up on this one, that the fixtures, the like-for-like fixture replacement, the same number of lamps. And prior to this gathering, we kind of went back through one of our projects that had analyzed projects that had about 1 million square feet of replacement, and about 12% of the lamps were removed through that, primarily 4 lamp to 2 lamp or 3 lamp to 2 lamp conversions. How much of that actually happens here? In other words, and does this also relate then to the too bright for comfort? Do you have maybe 3 lamp fixtures that if they'd been made 2 lamp, you'd have saved the cost of the lamp, you'd have saved the maintenance of the lamp, and you'd have got a better light level. How is that working out for ENS?
It goes right back to the planning and the proper analysis ahead of time. We use a pretty common used approach to assessing existing lighting. It isn't just counting lamps and ballasts, but it's interviewing the management, understanding what areas may need to improve their aesthetics, which would require a new fixture. It's involving interviewing the people, the employees that are working in each of these functional areas, to ask them what they need, better lighting, lower lighting. And then there's the environment. There's light coming in from everywhere. So you take into account the environment, the person, preferences, and the task that's being at hand there. So it's really doing that proper analysis. We don't recommend delamping ever, really. There's ways to get the proper light levels, but usually delamping is something that, again, you would do that, but not take into account these 3 critical areas.
So why would you not delamp? If you got more lamps than you need and more lights than you need, why would you not reduce the number of lamps and save money?
It would depend on what the task is being. You could, if the task is such that they need less lighting, the preferences of the person is they need less lighting, and the environment isn't affecting the amount of lighting. So again, it is possible, but usually it's not the right solution.
Okay, we need to come back to that because, again, you are absolutely the experts and we rely on you on many projects, but I think that issue we would.
Ian, Mike has a comment to make.
Yep.
Hi, yeah, I just wanted to expand on Jim's point. It's a good one. And an important thing to keep in mind is the objective in a lighting retrofit is always to deliver the right amount of light for the least amount of energy possible. So having a blanket policy in a healthcare setting, like delamping all 4 lamp fixtures to 2 lamps, is not really the right way to tackle this.
Well, with respect, Mike, that's not what was suggested. It's that is that where you've got more lamps than you need, you remove them, not that you simply delamp 4 lamp fixtures. That was not what was done, and that's not how it turned out. But if the light levels permit, I can't imagine why you wouldn't remove lamps from fixtures.
That's right, exactly. So it's all about making sure that you have the right amount of light for the optimal or optimized amount of energy. And Jim did hit on another important point with regard to fixture aesthetics, and paying attention to those lamp positions in a fixture is important. I think we've all probably seen those deep cell louver type fluorescent fixtures where they've delamped the center row and you end up with a dark band down the middle of a fixture. Yep. Paying attention to considerations like those are also important when you're making delamping choices.
Okay, and I'm watching the comments coming up. Larry, thank you for that. We're going to absorb all of this. Obviously, we kept this to a 1-hour webinar today because that's people's preference, but we will respond to all of the feedback coming here, and there's lots of good stuff in the chat box. And as you say, going back to Jim's comment, it's all about the initial assessment that be done well, because whatever you come up with, you're going to live with for the next 15 years and beyond, and there's no shortcut to, so it's not like for like, and it's not any standard, let's remove this, let's remove that. It's absolutely as a customized design to what's already there. So with those kind of questions in mind, the projects are often not delivering the savings as expected, too bright conversions, reducing the number of lamps, perhaps removing some fixtures in areas if they're not needed. That all speaks to the upfront way of doing this. So Jim, maybe you start with Rob on how did you procure your lighting project? Because it seems to us it's all about the procurement process that dictates the outcomes, if you like.
So I mean, overall procurement was done before my time here, so I'll have some minimal comments on it. But our capital folks put this out for bids, I guess, as a turnkey solution, just to provide specs on lights. So we would give them kind of how we run the facility now, and And I guess, you know, contractors or designers were tasked with coming up the best solution in their minds. And that's how we kind of doled it out from there.
Okay, so I think a bigger discussion than we have time for today, but one that we will continue with all of you and the other hospitals that have both done these and are planning these, is to test the idea: is there a better procurement process that gets you the upfront customization, but still the procurement folks can live with? And again, this is one of the areas where we're having the discussions with Shared Services West, the procurement, central procurement folks, as to how do we get the right outcome. And again, our starting premise is it begins with how you procure the project in the first place, that it's more of a performance-based scope of work than simply a low bid on a certain number of pictures. We also want to get deeper into, is there a role for in-house staff doing some of this work? Because we know a number of you have taken that approach, and what are the pros and cons there? And again, I'm kind of conscious of time. I think the stage is set with this. So the idea of the third-party lighting audit, obviously this is leading into the space of it's that initial audit and the terms of reference for that audit, and if you like, the life cycle quality of that audit that sets the stage for how well the project's going to turn out. And certainly Ontario Shores, we asked Rob to be on because he's really happy with how his project turned out. So this is an ongoing area of investigation. I hope you'll kind of stay tuned with us, and Harry will be interested in then relating all of this to the Alberta Health experience, where you've done a lot of this work over the years. And yeah, so that, again, thanks for the feedback from the floor, and forgive us for moving this along more quickly, but we need to get on to operating room ventilation now. And again, you will hear more about lighting as the year unfolds. Amity, next slide, please. So let me pass it over to you and the work that you've been doing with 3 of the hospitals on how that's coming together. I guess this is one, Alan, if you're on that, with Markham Stouffville, is going to be part of that case study that we'll be hopefully doing with you later this year, and so on. So OR ventilation, a big deal. We spent a fair amount of time on it, and very interested in the unfolding story as we go deeper into some of these system modifications that have been made. So getting it right the first time, Amandeep, over to you.
Thanks, Ian. Thanks everyone for joining today. So OR ventilation retrofits and operations. The goal of today's session is we're just trying to look for, as Ian mentioned, what is the best process in this to get these retrofits right at the first place. So the 3 case studies, we're gonna share that have all lessons learned from them, and we're just trying to kind of collect all those lessons learned and put it together in a package that becomes useful for anybody who's looking into doing these retrofits, so they could kind of get these things right and learn from other people's experience. So just going forward. So I'm going to be joined with me today with 3 hospital reps. So we have Schubert from Michael Garon, Franz from Office of Sustainability, Alberta Health Services, and also Viola from Black and Men Women's College Hospital. So just to kind of give you a background on the ORs, why this topic was sort of important, and you probably noticed in the previous workshops and webinars, we have covered this topic, and this is sort of a one of the series of this topic is we're sort of doing a continuation of that. So within Alberta and Ontario hospitals, you can see almost 56% and 42% in Alberta hospitals have only done the unoccupied setback. So the good thing in this is that half of the hospitals in Alberta and Ontario have currently unoccupied setbacks, but the other half of them don't. So we have good case studies out there that we kind of could use for these hospitals for the remaining hospitals to apply those lessons results. And this is one of the sessions we're currently doing based on those case studies. So the first, before sort of I introduce the first case studies, what we did here is check. So we, if you guys, you might have already seen this OR project checklist. It's available on the Greening Healthcare website, and you can always reach out to Mike if you want to have access to this. But what it did is we try to summarize these 3 hospitals using this checklist. So these are the things that currently these 3 hospitals did, and so the checklist is sort of divided into 2 sections: operational and control measures and retrofit measures. So in the operational measures, you're looking at sort of calibrating your airflows in those spaces, making sure there are no leaks, making sure the controls part of it's optimized, and sort of having a regular check on the recalibration and calibration of these sensors. So I'm not going to kind of walk you through this whole list, but this is sort of the list among Women's College, Alberta, Children's Hospital, and Michael Garden. These are the things they're currently already implemented, and the things that are currently planned to do that, which kind of are summarized in this checklist. On the retrofit side, it's sort of the key bullet items on the checklist is to within these hospitals is to see what are the key items that when you are sort of considering a retrofit project, these are sort of the items that you could consider in that project, sort of installing those VFDs, making sure there are VFD boxes to control the individual spaces, and also an opportunity to sort of do exhaust heat recovery if it's not been previously considered. So again, this is a summary of all 3 hospitals, how what are the key items within the checklist they have currently done, what are the things they haven't done so far, and they're sort of working on this. So one of the things I just want to point out here is the which we haven't seen with most of the hospitals currently not being done is the anesthetic gas recovery. We issued a bulletin, Greening Healthcare issued a bulletin on anesthetic gas recovery. So it's available currently on the Greening Healthcare website. Again, you can reach out to Mike on it. But that sort of bulletin sort of represents what is the importance of anesthetic gas recovery, and what are the current market players. And I think as for the Canada, we should be sort of proud in this at least field, because we're sort of the leading technical experts in this field, and we haven't seen any such technology out there in Europe or world. So Canada is sort of leading that front. So I highly recommend looking at that bulletin to review what are the options when you are actually doing a bigger capital project in your operating rooms. So what are the options you have for the anesthetic gas recovery systems? All right, okay. We're going to start with our first case study, which is Women's College Hospital. I just want to make sure, Bill, are you online?
Yeah, can you hear me?
Awesome. Yes, I can hear you. All right. So this Women's College Hospital is an ambulatory care facility. It had 8 operating rooms. All of them had VAV boxes. The Siemens was the VAS control provider. Overall timeline took 4 months. So I just want to bring in Abelia here into the discussion. Can you maybe, Abelia, walk us through how, I know there was something interesting that came out, which I kind of really liked about your process, was having an implementation plan. So can you sort of walk us through what was that plan, and what were your sort of stakeholder meetings, and what were the usual conversations you had with them? How did you kind of present this business case to them?
Yeah, thanks, Mandeep. So the OR exchange setback was originally part of our energy management plan for like the broader public sector. So in which, we created a plan with it for the OR exchange setback. So we created an energy working group, with the operations team, internal operations team at West College Hospital, Black and Mac, and all clinical services, finance, and all that. So the working group was meeting bi-monthly to create that plan. So part of the plan was to, get a consensus on which operating room to set a trial on. Part of the consensus was also like, getting the right timing to test our ideas. Also working with the operations team on ground, the boots on ground, to actually manually test the system. Do we actually have the capacity to do it without any significant capital upgrade? Also, we had to in the plan, what would be the impact in terms of particulate matter? So working with IP&C to kind of get an idea of the possible impact that this could have. Also meeting with direct clinical services or our manager in terms of their concerns. And one good concern that came out was, what will be the impact of implant storage? So I didn't know about that. So I had to also research, working with the team and also the implant manufacturer, just to get an idea of what it means in terms of impact. So all this put together, we set up an implementation plan, trials, and we went from there, looking at the energy reduction impact, the trial stage, and presenting it to the team, and we were able to scale it from there.
Awesome. I mean, given the request that your stakeholder made, having the case studies referenced and addressing the concerns around implant storage, doing a PM test testing, there seems to be stakeholders that actually were very engaged and I would say pretty demanding, in a sense that they made sure that all of those angles were covered. And I think, as you mentioned, for that to happen, you had to have an implementation plan, and which is what you were able to execute to make sure you meet their demands.
Right. We actually had to detail the implementation plan, which was forwarded to the IP&C team to actually, verify that we know what we are doing. And actually, it was approved immediately. They felt it's well thought out. We also shared some other case studies, like the greening healthcare case studies, in terms of what has been implemented elsewhere. So we were able to back it up with, living examples of the implementation as well.
Awesome. So that was sort of this, just to give you an gist of the project. So again, this is sort of a screenshot from the building automation system. And this was Women's College. You see eight operating rooms with a sterile core and the corridor on the side. Currently, the unoccupied mode is programmed at the VAV boxes. So basically, the way it works is the VAV boxes resets to an occupied and unoccupied mode, depending upon the time of the day schedule. This is slightly different than you will see in another case study where they use actual occupancy in the room. So, and the fan basically resets the VFD based on, once the box is closed as an unoccupied mode, the pressure builds up and the fan resets the VFD based on the static pressure sensor. And I think, Abhilya, you mentioned that you guys chose this path of sort of not relying on the occupancy because of the ambulatory care, that you already knew there was sort of a scheduled operating working hours in that facility, right?
Yeah, that's right. We know the occupancy hours, so there was no need to actually program it based on, an occupancy sensor sensing occupancy in the operating room. So, and we also created a switch could actually turn it to occupied mode instantaneously. So that's for emergency situation, which, we don't emphasize, but it's there to be used. And if there's something else, all they need to do is to reach out to the operations team on site and flip the switch straight up.
I remember from the previous conversation that you actually tested a lot around that mode. There was a concern with a few of the hospitals that when you have to switch to an occupied mode, how long does it take for your system to go back into the occupied mode, and does it actually have any sort of other issues around disturbing the space environment? So we actually, that was something I remember you guys did a lot of testing around that to make sure the system comes on in time before it gets implemented.
Yeah, it was one of the concerns raised, and we to clear that out during the testing phase to actually see that the system can actually ramp up on time to achieve the 20 exchanges per hour when the building is occupied. And initially, also we ensured that we had like 2 to 3 hours, buffer to cover that area. But over time, we're tweaking the hours now. So currently we're at 2 hours. So before occupancy, the system actually is running before occupancy, 2 hours before occupancy. I think there's still room for improvement on that. And in terms of, what are the impacts as a result of ramping up and ramping down, we had to engage industrial company to do particulate matter testing. So they did PM10 counting, and there was no impacts ramping up and ramping down.
Awesome. Okay, so this is sort of the results that you see before the VFD. You see the blue on the left is the VFD trend. Blue is your supply, orange is your red, and on the right is your trends for the same fan after the unoccupied schedules were implemented. So you can see that previously the fans were running at around 73 VFD speed, and once the unoccupied mode was implemented, they went back to in the unoccupied mode is around 55 or so. So there was considerable savings from this project. This is what the PM10 test reports that was conducted. So it was a 72-hour test, as I mentioned, just to satisfy the requirements for their infection control folks. If you look at the test results on the graph between minimum and maximum, this is sort of 72 hours. You can see from December 27 to December 30th. The particulate matter didn't change. Pretty much they remain the same during the occupied and unoccupied mode when the air change was reduced. So kind of again suggesting that none of these changes made any impact on the particulate matter levels itself. The project summary, basically this is the total expected, or actually savings, annual savings is around $22,000. Financial summary on this is because there was all infrastructure, it was pretty much phased. It needed additional testing and some reprogramming, and most of it was probably under existing contracts. So that's why the cost is less, and that's why you have awesome paybacks. I mean, this is sort of another example for a lot of hospitals out there who currently have the infrastructure in place, that it doesn't take much. It's just a initial upfront work that's needed to get this accomplished. Willie, do you want to add anything to it?
No, you're right. Yeah, I would say it even probably costs less than 10,000, but for sure, if we account for the internal labor, maybe around that. For the most part, it was covered by our service contract with the BS provider.
Awesome. Okay, I'm just gonna, and as we talked about, there are some additional savings around optimization, because one of the things that we noticed within all of these projects is that what is the right way to do this? I mean, at the first time. So one of the things as we talked about is optimizing the heat wheel operation. In a lot of the hospitals, especially around these air handling operating units, becomes a critical. And this is something you guys are currently working on. And also optimizing the supply and static pressure resets, another opportunity. A lot of the current hospitals that we are seeing that have been currently working. I'm gonna go to the next, given the time. Thanks, Avila, for your time. And I'm just we'll move to the next case study, which is Alberta Children's Hospital. I'm gonna bring France into the conversation. So project overview, it's a acute care facility, 10 operating rooms, again with the VAV boxes and on the supply and exhaust duct. One of the interesting thing about the project, maybe France, can you hear me?
Yes, I can. Can you hear me?
Yeah, I can hear you. Can you give us sort of a bit of background on how this project came into existence? I know you mentioned this is something was tied to another project. So if you can sort of give us an insights into what was the trigger point for this project.
Mm-hmm. Yeah, well, most of the preparation for this project was done before I joined AHS. This goes back to 2015. But there was work in the interstitial spaces above the operating rooms, and the IT project that was going on. So it was conduit being put in and wiring, so we could benefit from that activity and make sure that all the wiring for occupancy sensors and control was put in place without having to do too much extra work. So I believe that was one of the trigger points that made this project possible.
Awesome. I think, yeah, this is sort of again, with any hospital could be a different trigger point, but this was sort of the right opportunity to tag along there, because you don't get many opportunities opening the ceiling of your operating room. So if you, I mean, given that this kind of, you guys utilize that opportunity to implement this project. So what you see on this graph is the 2 units that are feeding, and on the top is the supply fan and total kilowatts for the supply and the return fan. And as you could see, it goes from 100 and sort of like in the range of 140 kilowatts, and goes at the nighttime and is unoccupied at 220 kilowatts. It matches with the occupancy schedule in that space. So the blue graph that you see at the bottom of this chart is the occupancy, actual occupancy sensors converted into percentage occupancy. So you can see at the nighttime when none of these rooms is occupied, the fans go down to 120 sort of kilowatt in total energy consumed or demand consumed. So this sort of, I think, triggered one thought with us, especially, is that as friends, we noted that we were expecting higher savings on this project, and this sort of brought us to kind of review what's going on in this project, right? And one of those opportunity, as we talked about, I'm just going to skip this slide and come back to this, is around static pressure reset. So when we sort of analyzed the overall project sort of requirements and the air testing reports, what you could see on this is a summarized VFD speed for AHU 6 and 7. And you can see around the occupied mode, it's the fans are running at 62 and 63. And in unoccupied, it goes to 56. So I mean, there's not a drastic change in sort of the VFD speeds when you goes from occupied to unoccupied mode. And it's sort of somehow related to this supplier damper position. When you look at the OR operating rooms from 1 to 11, so this is the tally of their average occupied VAV damper position, and then average occupied, unoccupied VAV damper position. So especially in the unoccupied mode, you can see all of those VAV dampers are like 54 or in that range or lower than that. So that means most of that pressure across that fan is being sort of wasted across these dampers. And during the occupied mode, all of them are below 80% except one room, which is at 95%. Again, when you look at the air testing reports, that room is currently at 24 air change. So it should be actually at 20 air change. So there's an opportunity around a lot of these projects, and similar opportunities we are seeing in most of the projects is around rebalancing those systems to actually match the CSA requirement, which is 20 air change rates, and then have an occupied and unoccupied static pressure resets on those modes. So again, this is sort of a lessons we're currently seeing within all of these hospitals projects, is it's around optimizing those projects and given the opportunity, have to work on those items. So just a project summary on that, given we are running just a little bit short on time, I'm just going to summarize that. So again, a simple payback of 4.6 year. This does involve a lot of retrofit work that you guys have to do. So that's why your capital cost seems to be higher, and it kind of gives a payback of 4.6 for the savings that you achieved on that project. So I know there's tons of I mean, work you guys did, and because of the time we could only cover so much. So Thanks, France. I'm going to move on to the next hospital, which is Michael Garan. I'm going to bring in Schubert here. Schubert, can you hear me?
Yeah, I can hear you. Can you hear me?
Yeah, I can hear you. Thanks, Schubert. Again, Michael Garan is an acute care facility with 15 operating rooms, and currently they are going through this project, which started in December 2020 and expected to finish in March 2021. And your current scope of work, it does involve updating the VAV controllers and upgrading the occupancy sensors, reprogramming, recommissioning. One of the interesting things I think we found, Schubert, is that managing these projects under operational budget. So that's something is a key interest to us, is that because a lot of the times we hear questions from hospitals is that they don't do these kind of projects because there's a capital constraint. So if you can sort of elaborate and maybe help other hospitals, how did you manage to sort of fund sources for this project or make a business case to your management?
So, actually, so first I'll answer your question. How did I? So this is basically savings year over year from other energy saving projects that we are doing here. So that's where we fund this from. And of course, we had a business case that we've created, but that was not to get the funding, because the funding was already available in our O&M budget. The business case was to get a buy-in from the surgery team, and of course, once we had that ready, we engaged them and presented what we were going to do, and of course, they were very interested in what we had to present, and they said, go ahead and do it, and then so yeah, so that's how we did it.
Awesome. One of the interesting things about I noticed, and we talked about this, Schubert, is around having access to these VAV boxes in the mechanical space, so you can actually work of them and not disturb the space. So this is, I mean, one of the unique design features that we've seen, and it's not available in a lot of the hospitals, but if you guys have it, definitely this is sort of a gold mine to work on these kind of projects where you do not disturb the existing operating spaces. As we mentioned, this project is currently in works. It's going to be expected to finish in March. This is sort of the overall payback for this project is around 3.7 years with a capital cost of around $120,000 and gives you an annual savings of $32,000. So another thing that and we briefly chat about it, Schubert, is around having additional savings. And can you kind of brief us on what you guys initially found when you sort of looked at this project around the heat wheel that you noticed it wasn't sort of operational?
Absolutely. So what happened is when our Honeywell BAS guy started to do the downloads and everything else, he found that the heat wheel was not working, and of course he found that we further investigation found that there's a VFD. It's a micro drive, half horsepower, and that is what caused the problem. So of course, in a couple of days, we're going to be having that micro drive replaced. And just to know, actually, we are completing this project this Friday. So as of Friday PM, we will have all the 15 ORs in scheduling mode.
Awesome. We will definitely keep an eye on the results and update the Greening Healthcare members on how those projects unfolds. Thanks everyone for your time. And again, this is a sort of a continued work in the operating room retrofit projects, and we will bring in more cases and more results and actual action items and sort of document the process. So anybody who's planning to do this so they're able to do this right first time. So I'm going to pass on this now back to Ian to review the 2020 program with us and give us an update on that.
Yeah, thanks, Amandeep, and thanks to your panelists. That was rapid fire as it was intended to be, and hopefully there's a lot of content there. In the last couple of minutes, I again encourage everybody who's got questions or comments on what you just heard, either on the lighting piece, because both of these are ongoing stories. This is not the end of it. So if you've got questions or comments, please do put them in now, and we will be responding to the Q&A. And we'll have a little survey for everybody after this event, easy one to respond to, but sets the tone, I think, for what we're planning for greening healthcare for 2021. I think you've seen this content before. We'll be having 5 webinars this year and the annual forum. We're really, and the forum will be in November or late November or early December. We're really hoping it might be in person by then, but if it's not, we will do it by probably a series of interrelated webinars to make the time manageable and so on. But one way or the other, the forum will be back this year. Each of these events will have each of the webinars will have a members corner, and I would remind everybody you're doing really cool stuff. And please, when Michael contacts you before the webinar, take a moment to let him know if you have a story that you'd like to share with everybody. We get consistently back from everybody what they value the most with greening healthcare is the feedback from your peers, not always listening to us. We'll keep you current with industry news, what's happening with federal government, provincial government, utility companies, and so on. The technical corner will be issues like water conservation and lighting. And we have a reverse osmosis project that Grand River has done. So we'll bring those together in little packaged. And today was really a kind of a double technical corner piece. And we'll keep bringing, again, we've been asked a number of times, we'll keep bringing technical experts and people from the membership together to share their experiences and insights. And again, we hear you loud and clear that that's where you get the most value. You'll be getting the annual report in May, which is your savings potential based on your 2020 energy use, and the targets will all be updated by then based on current good performance that so many of you are achieving. The first quarterly savings report will be out in the next couple of weeks, and we'll be following up with all of you on those quarterly savings reports, what you're doing, what's working, and that will take us effectively to the end of 2020 in terms of savings results. We will be doing the recognition and awards. You can expect to see those who've made significant savings in 2020. You can expect to see those awards in June. For the program content, there's just such good stuff coming out of the work that everybody's doing. There's a lot of interest, obviously, in Humber River, which started the most efficient among acute care hospitals we could find and has got progressively better since. So working with JCI and Plenary on really documenting what makes Humber River special that can be replicated by others. And if you're not familiar with the amazing work that Alan Kelly and his team are doing at Markham Stouffville Hospital, they've got energy valves installed, new air handling units, another operating room ventilation retrofit, done lighting in the past. So this is an ongoing success story, and we're going to find a way to package that and bring it back to everybody later in the year. For the first time, we're introducing individual hospital charrettes. We're talking about to sponsoring organizations about funding, bringing Amandeep's expertise together with your hospital and really digging deeper into the data and finding what your next level of savings will look like. So charrettes will be coming this year, and some of you may be invited to take part in those. The low carbon central plant now, we've renamed it because the trigger events that Amandeep referenced a couple of times, often those are a chiller replacement or a chiller plant expansion, where the option of the heat recovery chiller rather than a conventional centrifugal chiller becomes the trigger event that starts you down the low carbon kind of heating plant direction. But that will be a major initiative that we're talking to a number of industry players right now to support bringing that forward. And again, the idea is be prepared with your low carbon central plant plan for when the infrastructure money arrives. And we'll continue talking to you, developing tools and templates and checklists that can be useful as you carry your plan forward. So it's a full and rich program this year. We're conscious, very conscious of how stressed people are with timing. Again, the hospital sector is going to be under pressure for some time around COVID as it progresses. But we will look to work with you to manage timing and just make sure you have the right things in the right place at the right time for the best advantage of your hospitals. So as the final slide, you know where to find us. Michael is always there to get your calls, and Amandeep, if they're technical questions by nature, is happy to respond to those. And as always, thank you in the madness for making the time for Greening Healthcare. The next session will likely be in late March or early April, and we'll look forward to talking to you then. Thanks so much. Have a great day. Stay safe.